Number 63 reads, a 57-year-old alcoholic man is being treated for acute hemorrhagic pancreatitis. He was in the intensive care unit for 1 week, required chest tubes for pleural effusion, and was on a respirator for several days, but eventually improved enough to be transferred to the floor. 2 weeks after the onset of the disease, he begins to spike fever and to demonstrate leukocytosis. This is obviously another example of a pancreatic abscess. We would have preferred to detect one as it develops with the ongoing daily CT scans, but if it wasn't detected early, it may very well be that it shows up later like this one. So if we have a febrile illness begin within about 10 days of the onset of patient having had pancreatitis, that indicates the development of an abscess. We again would need a CT scan and percutaneous drainage. Now the next two vignettes give us another potential sequela of pancreatic disease. The 49-year-old alcoholic man presents with ill-defined upper abdominal discomfort and early satiety. On physical exam, he has a large epigastric mass that is deep within the abdomen and actually hard to define. He was discharged from the hospital 5 weeks ago after successful treatment for acute pancreatitis. But if we read the next vignette, we can see another way this same condition can develop. A 55-year-old woman presents with vague upper abdominal discomfort, early satiety, and a large but ill-defined epigastric mass. 5 weeks ago, she was involved in an automobile accident where she hit the upper abdomen against the steering wheel. Both of these are examples of a pancreatic pseudocyst. The disruption of the pancreatic duct, either from the inflammatory process and the pancreatitis or from the direct trauma on the second vignette, has led to leaking of pancreatic juice that now has accumulated nearby. The nearby where it usually accumulates is the lesser sac. It takes about 5 weeks to have enough of the fluid collection then to produce the pressure symptoms that we see in both of these vignettes. The early satiety, the vague discomfort, the palpable mass. Now we are going to confirm the diagnosis here with either a CT scan or a sonogram, both of which would show the collection of pancreatic juice where it doesn't belong. I should repeat that it could be someplace other than the lesser sac, somewhere near the pancreas. The lesser sac is a good example. Now what are we going to do with this patient? Our management of a pancreatic pseudocyst is based on our knowledge of a natural history. If we leave a pancreatic pseudocyst alone, there are 4 things that could happen to it. One is that it could reabsorb and go away. So a potential outcome of a pancreatic pseudocyst left alone is a happy one. It will disappear. But the other 3 are potentially very deadly things. A pancreatic pseudocyst can rupture into a general peritoneal cavity and produce massive chemical peritonitis. It can erode into nearby major blood vessels so the patient bleeds and exsanguinates. Or it can become infected, and then it becomes a pancreatic abscess with the septic problems that would produce. Fortunately, there is a timetable that enables us to have some guidelines for management. As a rule, obviously with many exceptions, but as a rule, a pancreatic pseudocyst that goes away by itself does so within the first 6 weeks or so from the time that it was discovered. As a rule, with exceptions, but as a rule, the bad complications, the rupture with the peritonitis, the bleeding, the infection, occur after 6 weeks. And so typically the first thing we do when we diagnose a pancreatic pseudocyst is kind of a watchful waiting. We repeat the CT scans or the sonograms to see if the cyst is shrinking or enlarging, if it is going away or not. But if we get to 6 weeks and the cyst hasn't gone away, and now we're entering the time frame when the complications are feared, then we need to do something. What is it that we do at that time? Let me give you a little historical perspective because there are a number of things that we can do. At first, whenever we had to do something about a pancreatic pseudocyst, we always had to operate. We had to open the abdomen, get to where that collection of pancreatic juice was. We could then drain it to the outside with a tube, or drain it inside to the GI tract. And obviously the latter was a far better thing to do, because if you simply put a tube there, the patient would end up then with a pancreatic fistula and not really have complete resolution of a problem until sometime later. But if we did an internal anastomosis, a cystogastrostomy or a cystojejunostomy, then the pancreatic juice was already redirected to the lumen of the GI tract where it belongs. And so the standard advice used to be, do a cystogastrostomy or a cystojejunostomy. But then radiological approaches came along to deal with this problem. And radiologically, it is possible to drain the pancreatic pseudocyst to the outside. Admittedly not an ideal solution, because a pancreatic fistula is now created that we will then in turn have to wait for it to go away. But of course, the good side of that is that an operation is not needed. So doing a percutaneous radiological drainage of a pancreatic pseudocyst became a very attractive option that did not require an operation. But there is now an even more attractive option, one being developed at the present time, and this is an endoscopic internal drainage. By doing a gastroscopy, getting into the stomach, looking at the bulging posterior wall of the stomach, making a hole in it and stapling it together, we can then create a cystogastrostomy, create an internal drainage. No pancreatic fistula needs to be imposed on the patient, and the whole thing can be done without an operation. Now, this is a recent development. Not everybody can do it. Not every institution can offer that treatment. But if you have that answer in the exam question, that certainly would be the ideal one. All right. We have one last case related to the pancreas. Vignette number 66. A disheveled, malnourished individual shows up in the emergency room requesting medication for pain. He smells of alcohol and complains bitterly of constant epigastric pain radiating straight through to the back that he says he's had for several years. He has diabetes, steatorrhea, and calcifications in the upper abdomen in a plain X-ray. This is a very good description of chronic pancreatitis. A terrible, disabling, very bad disease that some very unlucky patients have. These are typically alcoholic patients, began with alcoholic pancreatitis, that continue to drink, have had many episodes of pancreatitis, and eventually develop this burn-out end-stage disease. The pancreas no longer works. In fact, amylase is not one of the things you would find as a diagnostic finding on this patient. Because the pancreas no longer works, the patient has steatorrhea and diabetes. The pancreas is calcified. You can see it on plain films. But the patient really doesn't mind the steatorrhea. He doesn't care about the diabetes. He's not interested in the way the pancreas looks on X-rays, because what's killing him is constant pain. Epigastric, straight through to the back, day in, day out, every day, every night, constantly. These patients are wrecks. Patients that have chronic pancreatitis typically have lost their jobs, their families, their homes. They live under a bridge, tormented by the pain. They go to the emergency room looking for medication for pain. Everybody knows them in the emergency room because of repeated visits. And unfortunately, it's a difficult problem to treat. I hope that all they'll ask you in the exam is to identify, to diagnose that this is chronic pancreatitis, because that will be easy. To manage it, well, there are some things that are obvious. You would attempt to control the diabetes, and you would give pancreatic enzymes to take care of the steatorrhea. And beyond that, getting rid of a pain is a very difficult proposition. There are a number of operations that can be done that drain the pancreatic duct, and the guidance to decide which of those to do is obtain with an ERCP. So one potential answer if therapy is being pursued is an ERCP to see if there is some surgical derivation that would make sense. But even something as drastic as a total pancreatectomy doesn't take care of the problem. These patients, when they get total pancreatectomy, usually die because it's very difficult for them to control the very difficult diabetes that is created by total pancreatectomy. So there is no easy solution for chronic pancreatitis. Now let's move now to another area. We have a few vignettes dealing with hernias. Let me state at the outset that our standard recommendation for anybody who's found to have an abdominal hernia, whether it is inguinal or femoral or umbilical or ventral, any hernia affecting the abdominal cavity, the standard recommendation is to have it repaired electively to prevent the possibility of a loop of bowel getting trapped in that hernia and leading to the complication of intestinal obstruction and potentially strangulated obstruction. Now, there are obviously going to be some exceptions in individual cases. If a patient is dying of cancer of the lung and is then found to have an inguinal hernia, there's no point in fixing the hernia. But there are some other exceptions that we need to know, because across the board, there are some situations that we don't recommend the repair. Let me give you the first one here. Vignette 67. A 9-month-old baby girl is brought in because she has an umbilical hernia. The defect is 1 cm in diameter and the contents are freely reduced. Umbilical hernias, not inguinal or femoral or other locations, but umbilical hernias specifically, below the age of 2 may still evolve and close by themselves. And so we do not recommend the elective repair. The parents would be instructed on what signs to watch for should obstruction develop, but otherwise we wait. If the hernia is still there after the age of 2, then an elective repair would be done. Vignette number 68, an 18-year-old man has a routine physical examination as part of his college registration, and the exam reveals that he has a right inguinal hernia. The external inguinal ring is about 2.5 cm in diameter, and a hernial bulge can be easily seen and felt going down into his scrotum when he's asked to strain. He's completely asymptomatic, was not even aware of the presence of the hernia. Well, here the standard recommendation applies. Even though the patient is asymptomatic, even though he didn't even know it was there, once we find that there is an inguinal hernia, we know the risk for the bowel to be trapped is there, we would recommend elective repair. Now the next vignette gives us a little different situation. A 72-year-old farmer is forced by his insurance company to have a physical exam in order to be issued a life insurance policy. He has been healthy all his life and has never been to the doctor. At the exam, it is found that he has a large left inguinal hernia that reaches down into the scrotum. Vowel sounds can be easily heard over it. The hernia is not reducible. And he says that many years ago he used to be able to push it back, but for the last 10 or 20 years he has not been able to do so. The reason I put this vignette in here is to draw a distinction between what do we need to do with irreducible hernias that cannot be pushed back in. If we have a vignette that says we're looking at a patient that has an inguinal hernia, up until yesterday, the patient was able to push that hernia back in at will, but for the last 6 hours, he hasn't been able to do it and the thing is trapped out there. We want to do then pretty quickly an operation on that patient, because it is possible that this newly developed irreducible state is the beginning of a cascade of events that would lead to intestinal obstruction and then to strangulated obstruction. Since we would rather repair all hernias anyway, if it has become irreducible acutely, we want to repair it right there before problems develop. On the other hand, if we're giving a vignette like this one, This thing has been irreducible for 20 years. Well, we know the man has not been living with dead bowel in that hernial sac for 10 or 20 years. This is not an emergency. It still is an indication for surgery. This man has used an awful lot of good luck, and he needs that hernia repaired so that he does not go on to develop obstruction or strangulation. But you cannot say because it is irreducible, this is an emergency operation. In this setting, it is an elective operation. Let me wrap up the hernia review by pointing out that there is one disease affects the abdomen for which we use the word hernia, but it is not a hernia in the standard sense, and that's a sliding esophageal hiatal hernia. The presence of a sliding esophageal hiatal hernia is not in itself an indication for surgery. Now, other hernias in that area are. A paraesophageal hernia, we want to repair that. But a sliding hiatal hernia, even though we call it a hernia, it doesn't have a sac, a ring, it doesn't have the possibility for the bowel to be strangulated, etc. All right, let's move now to the topic of breast disease. Let me say at the very outset that breast disease is another good area for the multiple matching set in this exam. There are many breast conditions that can be identified with a very brief description, and therefore this is a good topic to be covered in our fashion exam. But let me also point out that if we're asked for the management of any breast condition, it pretty much begins always with ruling out cancer. Ruling out cancer is in the background of every management we do for breast problems. Now let me elaborate on that a little bit, because ruling out cancer, in fact, can only be done with certainty by one individual, the pathologist. Clinically or radiologically, we can suspect that a cancer is there. We may suspect that it's unlikely to be a cancer, but we cannot be sure. The only certain diagnosis to rule out or to diagnose cancer of the breast is a pathological diagnosis. But we can obtain the sample of tissue to be used by the pathologist in a variety of ways. In fact, there is a large spectrum going from very non-invasive to very invasive things we can do to make that pathological diagnosis. The least invasive thing we can do is a fine needle aspiration, an FNA. We get cells from the mass, we do cytology, totally non-invasive, can be done in the office, it's a very simple procedure to do, but of course doesn't have the same reliability as a tissue sample would have. As we move up the ladder into more invasive things, the next would be the core biopsy. Also obtained with a needle, but now rather than just cells through a very fine needle, these are little cores of tissue for histological examination. A little more aggressive than that, there are instruments that obtain an even bigger piece of the mass, the mammotome or the advanced breast biopsy instrument. And if we go further on, we could do an incisional biopsy, actually go to the operating room, anesthetize either the area or the patient, and with a knife and surgical instruments take a piece of the suspicious area. And finally, at the end of the spectrum, excisional biopsy. We actually remove the entire mass that is suspicious. How far along we go on this spectrum of available interventions depends on how likely we think the patient is to have cancer. And that in turn, the most important predictor is the age of the patient. Cancer of the breast is virtually unknown in little girls, very rare in the teens, begins to be seen in the 20s, then has increasing incidence, and when you get to old age, it's extremely common. In fact, if you remember having heard the quote that says 1 out of every 8 women in the U.S. develops cancer of the breast, that quote actually applies to women who have reached the age of 85. A good indication that the older you are, the more likely you are to have cancer of the breast. So if we have a question on the exam where a very young person has a problem with the breast, the likelihood that that is cancer is very small, and a very non-invasive test would suffice to rule it out, for instance, the FNA. But in a middle-age group where now the possibility of cancer is more a reality, then we would not settle for a negative FNA. We would want to have tissue, either core biopsies or bigger pieces obtained with a mammotome or the advanced breast biopsy instrument, or an incisional biopsy. And if it's even an older patient, we may not rest assured until an excisional biopsy has been done. Now, unfortunately, I cannot tell you where to begin in that process. There are some physicians who, confronted with a breast mass, always begin with the least invasive thing, like the FNA. On the grounds that were it to be diagnostic, well, then we've made the diagnosis without the need for something invasive. There are others, on the other hand, who, confronted with an older patient that they think is likely to have cancer, would begin with an incisional or excisional, feeling that anything less than that, they would not give credence to a negative report anyway. And so the important thing is not where we begin, but where do we end. In other words, you would be willing to end the investigation in a 17-year-old with an FNA. But you would not be willing to end the investigation in a 70-year-old until you have the whole mass out. And there is another topic that I need to talk about before we go to the vignettes, and that's the role of a mammogram. Mammograms were invented not to diagnose cancer of the breast, but to detect what probably is a cancer of the breast that's still too small to be felt with our fingers. So the mammography is actually a screening device, and we do it routinely as a screening device once women reach a certain age, 45 or 50 or 55, depending on which guidelines you use. But the role of the mammography is very confusing to the medical student who begins to deal with breast disease. We tell the medical students in the classroom, only the pathologist can make the call. Not the radiologist, only the pathologist. And yet, when they go and work in a breast clinic, and they see a patient with a breast mass, the first thing we tell them to do is get a mammogram. And they get all confused, why am I getting a mammogram, when the answer can only be given by the pathologist? Well, there is a rationale for it. Beyond a certain age, when the likelihood of cancer begins to increase, we feel that before an invasive investigation is done about a palpable mass, we should look at the rest of the breast tissue radiologically to rule out or to take care of other potential areas that might also need scrutiny. And so, in most institutions, there is some kind of a guideline or a rule. For instance, a commonly used one would be every woman after the age of 30. Before we do an invasive study of the breast tissue, we should have a mammogram to rule out other areas that may need to be investigated or to find it. I might point out that an FNA, a fine needle aspirate, doesn't really qualify as an invasive thing to be done in the breast. One can do an FNA in the office without necessarily having had a mammography first. But an incisional biopsy, core biopsies, excisional biopsy, after the age of 30 certainly should be preceded by a mammogram. And as long as we're talking about mammograms, let's wrap it up. What are the only contraindications to the mammogram? We don't do mammograms below the age of 20. Very young women have very dense breast tissue, and the mammogram cannot see pathology, because mammogram depends on the contrast between the parenchyma of the breast and the fat in the breast, and the very dense breast of a young person doesn't provide that contrast. And we don't do mammograms either in the lactating woman, because all you see is milk. But on the other hand, something that you might have thought was a contraindication for mammography is not. We can do mammograms if we need them in pregnant patients. There is no contraindication because of pregnancy. All right, let's begin to read vignettes. Vignette number 1, an 18-year-old woman has a firm rubbery mass in the left breast that moves easily with palpation. In this age group, that description of a firm, rubbery, movable mass is always a fibroadenoma. So if you're matching this one in an extended matching set, fibroadenoma, that's the answer. What if you're asked for management? 18 years old, very unlikely to have cancer. You certainly would not order a mammogram because below the age of 20, it's pointless to do it. Actually, there are two things you could do here. Both of them are equally good. You could do an FNA, or you could do a sonogram. Both of them are very good at confirming the diagnosis of fibroadenoma. And once we've done that, removal is at the option of the patient. Most women don't like to keep a mass in their breast. They want it out, and we are happy to oblige. But we cannot say it has to come out. FNA shows as fibroadenoma, or sonogram shows as a fibroadenoma. It could be left there if a patient prefers. Now, vignette number 2 gives you a variant of the preceding. A 14-year-old girl has a firm, movable, rubbery mass in her left breast that was first noticed 1 year ago and has since grown to be about 6 cms in diameter. In very young women, like this age, we sometimes see fibroadenomas that grow very quickly, and we call them giant juvenile fibroadenoma. We know it's a fibroadenoma. The age, the rubbery consistence makes it likely to be a fibroadenoma, and an FNA or a sonogram would confirm that. But here, with this rapid growth, we would certainly recommend removal. Otherwise, that thing is going to keep on growing and squash the rest of the breast tissue. Now, there's another variant. Not exactly a fibroadenoma anymore, but a first cousin of a fibroadenoma. Vignette number 3. A 27-year-old immigrant from Mexico has a 12 by 10 by 7 cm mass in her left breast. It has been present for 7 years and has been slowly growing to its present size. The mass, which is firm, rubbery, completely movable, is not attached to the chest wall or to the overlying skin, and there are no palpable axillary nodes. And our first inclination when we read that the mass is very big in the breast is to think, oh my God, it must be a cancer. But if a cancer had been in the breast for 6 or 7 years and reached the size this mass had, it would already be firmly attached to the chest wall. It would be ulcerating through the skin. The axilla would be full of metastases. So in fact, this is not a cancer. The history alone, the description is classical for a cystosarcoma phylloides. The cystosarcoma phylloides is seen in this age group, the late 20s. It typically has a long history, several years. It grows to a significant size, and yet it remains movable. It's not fixed. It's not attached to the skin. It doesn't have axillary nodes. The cystosarcoma phylloides is a benign tumor, but with malignant potential. It can become an outright sarcoma. The diagnosis requires tissue, so an FNA would not be sufficient here. Tissue diagnosis is needed. And then removal is certainly mandatory because of the possibility, again, of degeneration into a sarcoma. Let me make an observation, by the way. This was described as an immigrant from Mexico. There is actually no Mexico connection to the cystosarcoma phylloides, like there was with amoebic abscess. Often, if an exam question has to give you a patient who has remained untreated for many years, an attempt is made to justify how come the patient never had treatment. And sometimes the way this is done is by making the patient come from a less developed part of the world. The patient maybe grew up in the mountains in a little village where there was no medical care available. That's why it has grown to the size that it has. In fact, in my own practice, I might say as an illustration, most of the cystosarcoma phalloides I've seen, in fact, have been immigrant women who had been elsewhere for several years, and when they moved to the U.S., sought medical help, and we found a big cystosarcoma phalloides. All right, vignette number 4. A 35-year-old woman has a 10-year history of tenderness in both breasts related to menstrual cycle, with multiple lumps on both breasts that seem to come and go at different times in the menstrual cycle. She now has a firm, round, 2 cm mass that has not gone away for 6 weeks. This vignette includes actually 2 things. There is a description at the beginning which is classical for fibrocystic disease. Fibrocystic disease, which is also called mammary dysplasia and also called cystic mastitis, is a disease seen between the ages of 20 and 40. Painful, cyclical, lumps that come and go, which are cysts. And if that's all we were given, you could make the diagnosis and match it, and the extended matching set, and if asked for management, a mammogram would be done. So we have a baseline picture of what that breast looks like, full of cysts and fibrous tissue and so on, and be able to detect in the future the presence of something that might be a more hazardous thing. But this vignette has a second component. This vignette says that that lady with that history now has a firm, round 2 cm mass that has not gone away for 6 weeks. This is already beyond that menstrual cycle where typically the masses come and go. Now we have to do something about that mass. It's probably a cyst, but it could be a tumor. It could be a cancer. What are we going to do first? She's 35 years old, so let's do a mammogram before we start doing invasive things. Once we've done the mammogram and have identified that there is nothing else that needs our attention, what we do for what we suspect to be a cyst, like here, is we do aspiration of the cyst. This is not fine needle aspiration to get cells for cytology. This is actual aspiration, a bigger caliber needle and a bigger syringe to get fluid out of the cyst. If we aspirate that cyst and we retrieve clear fluid and the mass goes away, we're done. That clear fluid is thrown away, the mass disappears, end of investigation. If we aspirate and get bloody fluid, then we send that fluid for cytology. And if we aspirate and the mass doesn't go away or returns within a day or 2, then we're going to need tissue sampling. We're going to need some kind of formal biopsy of that mass. All right, vignette number 5. A 34-year-old woman has been having bloody discharge from the right nipple on and off for several months. There are no palpable masses. If that vignette appears on an extended matching set, the answer is intraductal papilloma. This is classical. Intraductal papilloma, which is a very small benign tumor, 2-3 millimeters in diameter, grows inside the duct. Classically produces this bloody nipple discharge in a young woman. But of course it could be carcinoma too. So in the management we need to rule out carcinoma. She's 35, she doesn't have anything palpable, we have to begin with a mammogram. If a mammogram were to show a lesion, this in fact would probably be a cancer. But then we would biopsy and proceed from there. The mammogram actually will not show the intraductal papilloma itself. As I pointed out, they're too small, 2-3 millimeters in diameter inside the duct. We can see them with a galactogram, or we can find them with a retroareolar surgical exploration, and we remove that segment of the breast so that the bloody nipple discharge is interrupted. Vignette number 6. A 26-year-old lactating mother has cracks in the nipple and develops a fluctuating red, hot, tender mass in the breast, along with fever and leukocytosis. This sure sounds like a breast abscess. Hot, tender, red, fever, leukocytosis. And in fact it is. But the reason that we can say with confidence it is because this is a lactating lady. Here is the rule. Only lactating women are entitled to get an abscess of the breast. Any other examination question that describes what appears to be an abscess of the breast but is not in a lactating woman, we have to think it's cancer until proven otherwise. Now this one is an abscess, and if you have this in the extended matching set, that's what it is, it's an abscess. If we're asked though for the management of the patient, we still want to rule out cancer like we do in every breast condition. Now here you would not begin with a mammogram. Remember, a lactating breast, all you will see in the mammogram is milk. No point in doing a mammogram. But as we do the incision and drainage, for which a lady will have to be anesthetized and draped and be in an operating room, rather than just cutting and letting the pus run out, we also take a little sample from the wall of the abscess for pathological studies, so we can be sure that it is not an infected cancer rather than a garden variety breast abscess. Opinion number 7. 49-year-old woman has a firm 2 cm mass on the right breast, which has been present for 3 months. Well, now this could be anything, but at age 49, the likelihood of cancer now is pretty significant. What do we need here? First of all, the mammogram, so we don't begin to do intrusive things unaware of the fact that another suspicious area is nearby or in the other breast. And after we've done that mammogram and confirm this is the only area we need to be worried about, we're going to need tissue sampling. I would not be opposed to beginning with an FNA, but I certainly would not end with an FNA. If you do the FNA and it diagnoses cancer, fine, you're ready to move. If you do the FNA and it's negative, you need core biopsy. And in fact, if you did the core biopsies and they were negative, you might need then incisional biopsy or excisional biopsy. Opinion number 8. A 34-year-old woman in her 5th month of pregnancy reports a 3 cm firm, ill-defined mass in her right breast that has been present and growing for 3 months. So now the complicating factor here is the lady happens to be pregnant. How does that modify our management of what could potentially be a cancer of the breast? It actually doesn't. As far as the diagnostic steps are concerned, they are the same. This lady can and should have a mammogram. Obviously, you're going to shield and protect the fetus, but she needs the mammogram. And then she needs the tissue sampling that would have needed otherwise. In fact, let me go further. Let's get ahead of ourselves. We have another vignette coming up in a little while. The only limitations on the pregnant lady that has cancer of the breast, only 2 limitations. We cannot give her chemotherapy in the first trimester of pregnancy, and she cannot get radiation therapy to the breast at any time during the pregnancy. I said radiation therapy. I didn't say x-rays. Diagnostic x-rays, yes, we can. Radiation therapy, we cannot. Those are the only 2 limitations. And it is not necessary to terminate the pregnancy. You know, at one time we used to think this was mandatory. There was a feeling a number of years ago that the presence of pregnancy fanned the flames in the cancer of the breast and made it grow very quickly in a very lethal fashion. And women used to be routinely told that the pregnancy had to be terminated immediately or else their life was in danger. Actually, it is not. So that's not necessary. Let me move on. Vignette 9, 69-year-old woman has a 4 cm hard mass on the right breast with ill-defined borders, movable from the chest wall but not movable within the breast. The skin overlying the mass is retracted and has an orange peel appearance. This is classical for cancer of the breast. And in fact, if you encounter this one in the extended matching set, that's a diagnosis, cancer of the breast. The retraction of the skin, the orange peel in a lady of this age, classical. Vignette number 10, a 69-year-old woman has a 4 cm hard mass in the right breast, under the nipple and areola with the ill-defined borders, movable from the chest wall but not movable within the breast. The nipple became retracted 6 months ago, another classical cancer of the breast. That retraction, either of the skin or of the nipple, that's the desmoplastic reaction around the breast cancer. Keep in mind, though, that some women have a retracted nipple and have had it all their lives. If that's the case, that's meaningless, okay? The point here on the nipple retraction is it became retracted 6 months ago. Before that, it was not. All right, so these are cancer of breast. What if you're asked for management? Well, you know, mammogram first, tissue sampling next, and you wouldn't stop until you have very good, generous tissue sampling to be sure. Vignette number 11. A 72-year-old woman has a red, swollen breast. The skin over the area looks like orange peel. She's not particularly tender, and it's debatable whether the area is hot or not. She has no fever or leukocytosis. Of course she has no fever or leukocytosis because she doesn't have an abscess of the breast. It looks like one. It's red, it's swollen. But we know that unless she were lactating at the time, which is not likely to be at age 72, that is not an abscess. And in fact, this is another classical presentation, not only of cancer of the breast, of the most lethal form of cancer of the breast. This is inflammatory cancer of the breast. We need the mammogram, we need the tissue sampling. In fact, the skin itself will be permeated with cancer cells. That's why it's red. And this lady, in fact, will need preoperative chemotherapy and radiation, but we'll get to that in a minute. Vignette number 12. A 62-year-old woman has an eczematoid lesion in the areola. It has been present for 3 months, and it looks to her like some kind of skin condition that has not improved or gone away with a variety of lotions and ointments. This is another classical presentation for breast cancer. This is Paget's disease. This is a breast cancer that is not palpable as a mass, but it is infiltrating the tissues underneath the areola. We start with a mammogram, we get the biopsies, and we proceed. This is again cancer of the breast. Vignette number 13 is an important one. This is a point that is always made by faculty when explaining the ins and outs of breast cancer to students. Let me read it. Vignette number 13. A 42-year-old woman hits her breast with a broom handle while doing her housework. She noticed a lump in that area at the time, and 1 week later the lump is still there. She has a 3 cm hard mass deep inside the affected breast and some superficial ecchymosis over there. The point medical school professors make all the time is a history of trauma does not exclude a potential diagnosis of cancer when otherwise it looks like it could be a cancer. In fact, often trauma is what brings to the attention of a patient an area of the body that already had a mass there. Now, this woman had been in the habit of doing breast self-examination like all women should. She should have discovered this before. But if she didn't, it may be that when she hit her breast and she felt it, she felt the lump. So we're not going to take an easy shortcut here and say, oh, that must be fat necrosis, that's a hematoma, that's nothing. No, we're going to assume this is cancer of the breast. She needs a mammogram first. She needs the tissue sampling after that. Another presentation yet for breast cancer. Vignette number 14, a 58-year-old woman discovers a mass in her right axilla. She has a discrete, hard, movable 2 cm mass. Physical examination of her breast is negative, and she has no enlarged lymph nodes elsewhere. If this vignette had been a 22-year-old lady has a palpable mass in the axilla, and then The vignette went on to say she also has enlarged nodes in the neck and the other axilla. You would be thinking of lymphoma. But a woman in this age group, 58, only that axillary lump there, nowhere else, this is probably breast cancer, metastatic to the axilla. Now, how come the primary isn't palpable? Because it may be very small. Remember, that's why mammography was invented in the first place. So we could detect the breast cancers that are too small for the fingers to feel. You need a mammogram on this lady. That's the first thing you want to do. That mammogram will probably show the primary tumor, and then you can proceed. If not, the next thing to do would be get that node out of the axilla. We can do then a biopsy of that axillary node, find out what it is. Vignette number 15. A 60-year-old woman has a routine screening mammogram. The radiologist reports an irregular area of increased density with fine microcalcifications that was not present 2 years ago in a previous mammogram. This is the other way, in fact, of detecting cancer of the breast. One way is by feeling a mass in the breast. The second way is by seeing it in a mammogram. Now, I don't think they're going to ask you on the USMLE to actually read mammograms. Mammograms are highly specialized types of X-rays. Radiologists who do it often have additional training for this particular purpose. Sometimes they even specialize on reading mammograms. But you are expected to know what are the radiological findings that lead a radiologist to suspect cancer. Well, they are the ones described here. It's an irregular density. It doesn't have sharply delineated edges. It's an irregular density, increased density. It has fine microcalcifications. And one thing the radiologists rely on a great deal, it wasn't there 2 years ago. You know, when you go to one of those dark rooms where radiologists read their films, when they are reading mammograms, they are reading the present one, and they have right there in the view box the one from a year ago or 2 years ago, so they can compare one with the other. All right, what are we going to do? We've already done the mammogram. The mammogram is what revealed a suspicious area. Well, we know the next step is tissue diagnosis, but how are we going to do a biopsy if we cannot feel it? Well, we don't. The radiologist does. The next move here is radiologically guided core biopsies. Guided with a mammogram machine, the radiologist is able then to put needles in that mass, the big, not the fine needles for FNA, but the big needles that get cores of tissue, and do several passes and get 8 or 10 or 12 little samples of tissue from the mass for the pathologist. If by chance those samples were not satisfactory to make a diagnosis, we can then remove it surgically. The lady would come to the X-ray department in the morning. Under mammographic guidance, the radiologist would place a wire. It's a wire that has a hook. A wire where the mass is. The wire goes through a needle. The needle and wire go through the skin, and then the paper cup is taped so that it doesn't get moved or disrupted. The lady then comes to the operating room, and in the operating room, with the lady suitably anesthetized and so on, we'll remove that piece of the breast in which the wire is. That then goes to the radiologist first, so they can do a mammogram of the specimen and verify, yes, the area we're concerned about is in the specimen, and then it goes to the pathologist. All right, let's now move on. What do we do once we've made the diagnosis? Vignette number 16. 44-year-old woman has a 2 cm palpable mass in the upper outer quadrant of her right breast. The core biopsy shows infiltrating ductal carcinoma. By the way, infiltrating ductal carcinoma is the standard garden variety cancer of the breast. The mass is freely movable, and her breast is of normal, rather generous size. She has no palpable axillary nodes, and the mammogram showed no other lesions. Presently, there are 2 operations that can be offered to the lady who has a cancer of the breast. If the cancer is relatively small in a relatively large breast, and it's far away from the nipple and areola, we can offer the lady a lumpectomy. We remove only the mass with the surrounding tissue, but not the rest of the breast. We also have to do some axillary sampling, and then post-op the lady needs to have radiation to the remaining breast that was operated on. This is one of the options. The second option, if the mass is big and the breast is small, or the mass is near the nipple and areola, where saving the rest of the breast is not feasible technically. The second option then would be a modified radical mastectomy, which already incorporates as part of the procedure the axillary sampling. Let me point out that I'm using the words axillary sampling deliberately. At one time I would have said an axillary dissection, because an axillary dissection was the only way to know if tumor was growing in the axillary nodes. Now there are other ways. We can do a sentinel node biopsy. We can inject radioactive material in the tumor, have it migrate via the lymphatics, be trapped by the first node, which then can be recognized by the radioactivity that it emits, and then we biopsy that node. That's the sentinel node. Or we could do the more traditional axillary dissection. Now you might ask, why do we have to do axillary sampling when the vignette says there were no palpable axillary nodes? Because negative palpation of the axilla has at best a 50% reliability, which is to say has no reliability whatsoever. If it had been positive, it would have been useful. Probably there are tumor metastasis there, but a negative palpation of the axilla doesn't preclude the need to do the axillary sampling. All right, let's move to the next one, which I think will then be clear what the course of action is to be. Vignette number 17. A 62-year-old woman has a 4 cm hard mass under the nipple and areola of her smallish left breast. A core biopsy has diagnosed infiltrating ductal carcinoma. There are no palpable axillary nodes, and the mammogram shows no other lesions. This is a larger mass in a smaller breast. It's right underneath the nipple and areola. Preservation of the breast is not possible. The only option for this lady is a modified radical mastectomy. She doesn't need post-op radiation. That was required if we had done the less aggressive operation of a lumpectomy. All right, let's keep moving. We might be given questions on the exam that rather than having the standard infiltrating ductal carcinoma, have another type of breast cancer. Vignette number 18. A 44-year-old woman has a 2 cm palpable mass in the upper outer quadrant of her right breast. A core biopsy shows lobular cancer. Vignette number 19. A 44-year-old woman has a 2 cm palpable mass in the upper outer quadrant of her right breast. A core biopsy shows medullary cancer of the breast. And we could go on with other variants of breast cancer. Here's the bottom line. There are only 2 variants that would call for different management. If the vignette said inflammatory cancer of the breast, then we need to do radiation and chemotherapy before we attempt surgical resection. And if the vignette were to say carcinoma in situ, it would also have a different meaning, which we are about to see in a forthcoming vignette. On the other hand, all of the other variants, even though they have slightly different behavior and so on, are treated the same way. So both of these ladies, the lobular cancer, the medullary cancer, they would be treated the same way as if they had an infiltrated ductal carcinoma. I might point out, just out of curiosity, that the lobular cancer is the one notorious for having a higher incidence of bilaterality. But it is not high enough to justify bilateral mastectomies to begin with in every patient that has that kind of cancer, so that the management again remains the same. But now let's talk about that one that we said was an exception, vignette number 20. A 52-year-old woman has a suspicious area on mammogram. Multiple radiologically guided core biopsies show ductal carcinoma in situ. Now, if it is in situ, this is a tumor that does not yet have the capability to metastasize. So axillary sampling isn't needed here. All we need to deal with is a primary tumor. Now, the standard recommendation, and this is something that is changing, but the standard recommendation here has been to do a simple total mastectomy. Take that entire breast out. And this rather radical approach for what is a very incipient carcinoma is based, or has been based, on the fact that that offers pretty nearly 100% likelihood of cure. Because since this tumor doesn't have metastatic potential yet, if we take all that breast out, we're done with that tumor. Because we know that if we simply resect that tumor and leave the breast behind, there's a very high incidence of recurrence. And then once it recurs, it may no longer be in situ, so that opportunity for 100% cure is gone. There is, however, a tendency presently to be more conservative with the carcinoma in situ, and to apply to the carcinoma in situ the same thinking that has already been amply proven to be adequate for the infiltrating ductal carcinoma, namely that if we do a less than complete mastectomy, if we do a lumpectomy, we follow it with radiation therapy to minimize the likelihood of local recurrence. So there are many physicians presently doing a lumpectomy and post-op radiation for the carcinoma in situ. There are even some who say if a carcinoma in situ was discovered on mammogram and it was truly a very small incipient thing, that maybe the lumpectomy is enough even without the radiation. But I don't think that's yet the correct answer on the exam. Thing number 21. A 32-year-old woman in the 7th month of pregnancy is found to have a 2 cm mass in her left breast. Mammogram shows no other lesions, and core biopsy reveals infiltrating ductal carcinoma. We went through this a few minutes ago. We don't have to recommend termination of a pregnancy. It's not needed. We can go ahead and proceed with either a lumpectomy or a modified radical mastectomy. And the only limitation here, if we elected to do a lumpectomy, then that post-operative radiation will have to wait until she delivers the baby. Because remember, that was one of the only 2 limitations: no radiotherapy to the breast during the pregnancy. Opinion number 22. A 44-year-old woman shows up in the ER because she's bleeding from the breast. Physical exam shows a huge, fungating, ulcerated mass occupying the entire right breast and firmly attached to the chest wall. The patient maintains that the mass has been present for only a few weeks, but a relative indicates that it has been there at least 2 years, maybe longer. You know, we still see these very tragic cases of neglect and denial. You know, denial is a very human trait, and we shouldn't be judgmental about it. This happens, this can happen. So what do? We recognize clinically that this is a cancer of the breast. We, of course, would confirm it with a biopsy, which can be done with this enormous amount of tumor mass available. And once we know, yes, this is cancer of the breast, we don't give up. Cancer of the breast responds significantly to chemotherapy and to radiation. So even though this is clearly inoperable, we don't leave the lady with this bleeding, fungating, stinking necrotic mass. We would give her radiation and chemotherapy, or chemotherapy alone. And we sometimes are pleasantly surprised by significant reduction in the size of that tumor that enables then at least a palliative mastectomy to follow. All right, let's keep pursuing this subject as we're not done yet. When we treat breast cancer, we treat the cancer that's in the breast, but we also must be alert to the possibility that the lady may already have systemic extension of the tumor that also requires treatment. Let's keep on reading. Vignette number 23. A 37-year-old woman has a lumpectomy and axillary dissection for a 3 cm infiltrating ductal carcinoma. The pathologist reports clear surgical margins and metastatic cancer in 4 out of 17 axillary nodes. This is proof that the lady has systemic disease. In fact, this is why we do the axillary sampling. We don't do the axillary sampling to cure the cancer that may be in the axilla, because once there is cancer in the axilla, that is in fact a signal that says the patient already has cancer elsewhere. Maybe not clinically evident yet, but she has it. So this lady needs systemic treatment. Well, here is the rule for the systemic treatment. This is a rule with a million exceptions, with many variations and permutations in real life, but our best guideline for the exam. The rule is, any patient that has positive axillary nodes needs systemic therapy. If the patient is premenopausal, we prefer to use chemotherapy. If the lady is postmenopausal, we prefer to use hormonal therapy, tamoxifen, and this choice is made even easier if the lady happens to be estrogen and progesterone receptor positive when we test the tumor. We also have to give chemotherapy to anyone who has already distant metastases that are already obvious, not only the prediction that we get from the axillary metastasis, but already brain or liver or bone metastasis. Let me repeat them. Premenopausal women, we prefer chemo. Postmenopausal women, we prefer tamoxifen. The choice is made even easier if they are receptor positive. And anyone with distant metastasis needs chemotherapy. So now if we read back this same vignette again. The lady has positive metastatic cancer in 4 out of the 17 nodes. Her age is 37. This is a premenopausal woman. This lady needs chemotherapy. Vignette number 24. A 66-year-old woman has a modified radical mastectomy for infiltrating ductal carcinoma of the breast. The pathologist reports that the tumor measures 4 cm in diameter, that 7 out of 22 axillary nodes are positive for metastasis. The tumor is estrogen and progesterone receptor positive. They gave you an easy question because you already knew, given the age, postmenopausal, 66, that the preferred treatment would be tamoxifen. And they made it easy on you because she is receptor positive. Vignette number 25. A 61-year-old woman has a lumpectomy and axillary dissection for infiltrating ductal carcinoma of the breast. 7 out of 23 nodes in the axilla have metastatic disease. She is also found to have liver and bone metastasis. There is already evidence of distant metastasis. This lady needs therefore chemotherapy. The last 2 vignettes pertaining to the breast bring up situations that acquire particular meaning because of the history that the patient has had cancer of the breast. Vignette number 26. A 44-year-old woman complains bitterly of severe headaches that have been present for several weeks and have not responded to the usual over-the-counter headache remedies. She is 2 years post-op from modified radical mastectomy for T3N2M0 cancer of the breast, and she had several courses of post-op chemotherapy, which she eventually discontinued because of the side effects. Had that history of breast cancer not been there, you might not have gotten too excited about headache, because headache is a very common symptom. But somebody that has headaches of new onset, recent onset, severe headaches, are not responding to medication, who has a history of cancer of the breast not too far back, that's going to be brain mets until proven otherwise. This lady needs a CT scan of the head. It will probably show brain mets. We will probably resect them if they are resectable, or treat them in some other way if they are not. Incidentally, this vignette here uses the TNM classification, T3, N2, and 0. TNM classification is absolutely essential to be used if you are doing any kind of research on cancer, because you need to be able to compare apples to apples and oranges to oranges. And therefore, clinicians are also encouraged to note on the record the TNM classification of tumors, so those tumors could eventually be studied in retrospect if it is desirable to do so. But from the viewpoint of preparing for the USMLE, I would suggest that you do not attempt to memorize the exact meaning of the TNM classification in each of the many, many different tumors that people can have. In fact, I've done a great deal of work in surgical oncology during my career, and I have had an opportunity to interact with medical oncologists a great deal, and radiation oncologists, people who devote their entire career to the treatment of cancer. And even those very specialized persons often carried in their pockets the little laminated cards that had the TNM classification for each of the common tumors. If they don't commit it to memory, why should you commit it to memory? All you need to know. T stands for the size of the primary tumor, and the scale is typically 1 through 4. So T1 is a very small tumor, and T2 is bigger, and T3 is pretty big, and T4 is humongous. N is the status of the nodes. N0 would mean no evidence of nodal metastasis. At N1 there are metastases. And in some tumors there is more than N1, depending on how far up the chain there are metastases. So N2 means pretty extensive nodal metastasis. And the N is either 0 or 1, the distant metastasis. Either they are there or they are not. So this lady, looking back in retrospect, had a pretty significant tumor. A T3 big primary tumor with very extensive nodal metastasis, N2. And so again, the management for this lady calls for a CT scan of the head. And vignette number 27 is another variant of the same idea. 39-year-old woman completed her last course of postoperative adjuvant chemotherapy for breast cancer 6 months ago. She comes to the clinic complaining of constant back pain for about 3 weeks. She's tender to palpation over 2 well-circumscribed areas in the thoracic and lumbar spine. Again, given the history of a breast cancer, we have to assume these are bony metastases, probably to the pedicle of the vertebra, which is where they typically are. If you're asked, what are you going to do next? Your temptation might be to say, okay, bony metastasis, let me get an X-ray of that bone. But X-ray is not the most sensitive way to detect the metastasis if it is a very small incipient one. Bone scan is the answer. The radionuclide scan of the bone, not CT scan of the bone, bone scan. Bone scan is the most sensitive test to show the presence of bony metastasis. It is unfortunately not very specific. And so if the bone scan is negative, there's no point in doing any other test, because no other test will show tumor there. But if the bone scan is positive, then we need X-rays. And the X-rays are then primarily to rule out the other things that could have made the bone scan light up. The arthritis or the old fracture, or something else. And then we do what we can for those metastatic growths in the spine. We can give them radiation therapy. The orthopedic surgeons can do things to stabilize that spine and prevent it from breaking. The lady could wear braces or things like that. All right, we're done with the breast cancer. Let's now move to the topic of endocrine disease. Vignette number 1. A 62-year-old woman was drinking her morning cup of coffee. At the same time she was applying her makeup. And she noticed in the mirror that there was a lump in the lower part of the neck visible when she swallowed. She consults you for this, and on physical exam you ascertain that she indeed has a dominant 2 cm mass on the left lobe of her thyroid, as well as 2 smaller masses on the right lobe. They are all soft, and she has no palpable lymph nodes in her neck. The lady has a thyroid mass, actually several thyroid masses. What's the question then? What's the issue? Twofold. Thyroid masses may be adenomas that are hyperfunctioning, what we call a hot adenoma, leading to difficulty for the patient because of hyperthyroidism. But we know that's not what it is here. We know it is not because, remember, we mentioned some time ago, it was sort of a rule for this exam, that if some important clinical findings essential to suspect the diagnosis are not in the vignette, we have to assume they are not in the patient. This vignette doesn't say that this lady has heat intolerance and is fidgety all the time, and is moving all the time, and has tachycardia and has palpitations and moist skin. We don't have any of the clinical indications to think that she has a problem with function. All we are told is there is a mass. Well, then the question is it cancer or not? And the way we answer that question in thyroid masses is with an FNA. We do a fine needle aspirate of this bigger dominant mass. The final aspirate could be red, negative, in which case we leave the lady alone. It could be red tumor, in which case we operate the lady, or if it is red indeterminate, we also would operate the lady. Now, this approach is based on the fact that most thyroid masses are benign rather than malignant. And so if we were to do a thyroidectomy on every lady or every patient, for that matter, that has a palpable thyroid mass, we'll be doing an enormous amount of thyroidectomies for benign disease. So they need to be selected. Who gets the thyroidectomy or the lobectomy? This has to be selected, and that's the way we select them, with the FNA. All right, here's another example, vignette number 2. 21-year-old man is found on a routine physical examination to have a single 2 cm nodule in the thyroid gland. He had radiation to his head and neck when he was 13 years old because of persistent acne. His thyroid function tests are normal, and FNA is read as indeterminate. This young man is going to go to the operating room. In fact, he has a number of things that are all indications of higher risk. We're more concerned in the young rather than the older person when we find the thyroid nodule. We're more concerned that the male is more likely to have cancer than the female. A single lump is more worrisome than 2 or 3. Radiation to the head and neck is another item. But all of that is really irrelevant, because if we have an FNA read as indeterminate, that's a decision. The gentleman needs an operation. Vignette number 3. A 44-year-old woman has a palpable mass in her thyroid gland. She also describes losing weight in spite of a ravenous appetite, palpitations, and heat intolerance. She's a thin lady, fidgety, constantly moving, with moist skin and a pulse rate of 105. We now have a description, a clinical description of hyperthyroidism in a lady who also happens to have a mass. This mass could very well be that hot adenoma, that functioning adenoma. Well, the first thing we need to do is confirm with the laboratory that indeed she is hyperthyroid. We can do that with a T4 or a TSH. The T4 at the present time, the laboratories all give you and measure for you the free T4, not the entire T4, including the bound and the free. So it's a reliable measurement, T4, which will be high. Or you could do it with a TSH. The TSH would be low and confirm the diagnosis. The TSH, I believe, is a little cheaper to do than the free T4. We've confirmed that. But now we need to make sure, where is that excessive hormone coming from? Is it from that lump alone, or is it from the rest of the gland that happens to be lumpy? So we do then a radioactive iodine scan. And the radioactive scan will show where is the iodine that is captured and made into a hormone. And if the thing that lights up is the mass, then we know that we can surgically resect that portion of the thyroid gland and cure the lady. But if the entire thyroid is the one that is hyperfunctioning, then we probably would treat the lady with radioactive iodine. Vignette number 4. A 22-year-old man has a 2 cm round, fair mass in the lateral aspect of his neck, which has been present for 4 months. Clinically, this is assumed to be an enlarged jugular lymph node, and it is eventually removed surgically. The pathologist reports that the tissue removed is normal thyroid tissue. It is not. At one time, we used to think that it was possible for the thyroid to get confused and end up on the side of the neck. And this thought made sense in a way, because we know the thyroid is an organ that migrates. The thyroid develops first at the base of the tongue and then moves out of there. It may leave little pieces around the hyoid bone, the thyroglossal duct cyst. It then goes to the normal location, but it could keep on going, so we see thyroids that are abnormally located in the mediastinum, in the anterior mediastinum. So the thought was, there's a thyroid that went out to the side, but it doesn't happen. That migration of the thyroid is only in the midline. When we see thyroid tissue on the side of the neck, what that represents is metastasis from a follicular cancer of the thyroid that has completely replaced the lymph node. In fact, the pathologist here had been told this tissue came from the side of the neck. The pathologist's report would have said metastatic follicular cancer. Now, the pathologist wasn't told. It was just given a piece of tissue and said, tell me what that is. Well, it may very well look like just normal thyroid, because follicular cancer is the one most difficult to recognize with a small tissue sample. The other types of thyroid cancer have a more obvious pathological picture. So in this particular vignette, the diagnosis then would be metastatic follicular cancer of the thyroid. The next step in management is a thyroid scan to see if we can identify the primary, and then the surgery that would be necessary. Move on to vignette number 5. An automated blood chemistry panel done during the course of a routine medical examination indicates that an asymptomatic patient has a serum calcium of 12.1 in a lab where the upper limit of normal is 9.5. Repeated determinations are consistently between 10.5 and 12.6, and the serum phosphorus is low. This is the present day way in which we see patients that have a parathyroid adenoma and have hyperparathyroidism. In the not too distant past, these patients went on to become symptomatic before we recognized them, and we remember the characteristics of the disease. By the old mnemonic, there was a disease of stones and bones and abdominal groans, kidney stones and cystic degeneration of the bone, and GI complaints, pancreatitis, peptic. But nowadays, we have those automated blood chemistry panels where you want a particular test and you get another 10 or 15 values that you had not even asked for. Nowadays, this is the way we find it. We diagnose it when they are asymptomatic. It's a finding. It's a laboratory finding. You might say, if the patient is asymptomatic, why bother the patient? Well, because we know the natural history of this particular condition. And it turns out that this is one with a very high rate of conversion. It's about 20% per year. And so we don't wait until these patients have the stones and the bones and the abdominal groans. We go ahead and treat them when they are asymptomatic. So the next thing we need to do is verify that indeed they have excessive parathyroid hormone. We therefore do a PTH determination, parathyroid hormone determination. The parathyroid hormone value is read in conjunction with the serum calcium. A high hormone alone doesn't mean anything, because if your serum calcium happens to be low at that time, it is normal to have a high hormone. This is a feedback mechanism. But if there is a high level of hormone at the time when there's a high level of calcium and the hormone should have been suppressed, then you have the confirmation. Most of these, about 90% of them, are adenomas rather than hyperplasia, and will remove typically the offending adenoma, and it may help to localize it prior to surgery, to do either sonograms or CT scans or a radionuclide scan, systemic scan, one of those radionuclide studies that give us the location of endocrine glands. All right, the next vignette, vignette number 6, is one of that will probably come to you with a couple of pictures. There'll in fact be 2 pictures on the screen as you get this question. One will be a picture of a lovely looking young lady. And next to that, there will be a picture of a monster. And then the text will say that this person who now looks like a monster is the same individual who a year ago looked like the other picture. And then when you look in detail at this person that I'm describing as a monster, you realize that that person has a round face, full of pimples and with hair, that there is a hump in the posterior part of the neck, the so-called buffalo hump, that there are supraclavicular fat pads, that this individual has truncal centripetal obesity with stria and abdominal wall, thin spidery extremities. We recognize immediately the picture of Cushing's. And then the vignette may give you the other manifestations of Cushing's disease. The hypertension, the diabetes, the osteoporosis, the amenorrhea, these wide mood swings that may even have a patient end up in a psychiatry service. All right, so we have our suspicion this is probably Cushing's disease. How are we going to work it up? We begin by measuring cortisol, and we do these both AM and PM cortisol determinations, because they are going to be high and no longer have the diurnal variation that you have in normal people. And then we do those famous dexamethasone suppression tests that you probably have memorized 3 or 4 times and already forgotten 3 or 4 times. We begin by suppressing the lady with a small dose of dexamethasone. Dexamethasone is a very powerful synthetic steroid that even at very small dosages will suppress the adrenal glands of normal people. And so if the lady suppresses at a low dose, she may be an obese, hairy lady that looks awful, but she doesn't have Cushing's disease. However, if she doesn't suppress at a low dose, she does have Cushing's, but it could be due to a microadenoma in the pituitary gland, driving both adrenal glands to be hyperplastic, or to an adenoma in one of the adrenal glands, directly making cortisol. So we do the suppression again now at a higher dose. If she suppresses at a high dose, she does have the microadenoma and the big adrenal glands. If she doesn't suppress at the higher dose, the problem is in the adrenal gland itself, or it could also be a paraneoplastic syndrome from a tumor elsewhere that's making the hormone. Depending then on the findings on the suppression test, we will do MRI of the pituitary gland or CT scan of the adrenal glands and remove the offending microadenoma here or adenoma in the adrenal gland. Vignette number 7 deals with a rare but fascinating disease that lore has it is very commonly asked about on exams. In fact, medical students often complain about the preoccupation they think their faculty has with trivial, rare, very esoteric diseases that are almost never seen in practice. And every time they talk about that fascination that the faculty has with the very esoteric, the example they use is Cushing, The example they use is the Solinger-Ellison syndrome, the gastrinoma. And they say, and they may be right, that there have been more questions on examinations about gastrinoma than there have ever been patients who had a gastrinoma. Whether that's true or not, really the complaint is misplaced. Because a question that you might find in the exam dealing with the gastrinoma, with the Solinger-Ellison, would be a very easy question to recognize. Because it is simply a patient with extremely virulent peptic ulcer disease. Peptic ulcer disease that doesn't respond to the usual therapy. Peptic ulcer disease that is more extensive than you normally would see. And even if you need a little more detail, often peptic ulcer disease that also has watery diarrhea. Let's read the vignette. A 28-year-old woman has virulent peptic ulcer disease. Extensive medical management, including eradication of H. pylori, fails to heal her ulcers. She has several duodenal ulcers in the first and second portions of the duodenum, and she has watery diarrhea. This is classic. This is Solinger-Ellison. This is a gastrinoma. Extensive peptic ulcer disease, unresponsive to management, watery diarrhea. Well, we're going to begin the workup by measuring serum gastrin. That's the elevator hormone. Later, CT scans of the pancreas to see the primary tumor, and eventually, hopefully, a resection of the gastrinoma. Now, vignette number 8 has another endocrine disease that is not common at all, but leads to some very interesting differential diagnoses. A second-year medical student is hospitalized for a neurological workup for a seizure disorder of recent onset. During one of the convulsions, it is determined his blood sugar is extremely low. Further workup shows that he has high levels of insulin in the blood with low levels of C-peptide. The vignette has established a connection between impressive neurological signs and symptoms and a low blood sugar. And so we have reason to believe hypoglycemia is responsible for the neurological manifestation. Now the question is, why is there hypoglycemia? If you go to a textbook and read about hypoglycemia, there'll be a big table, it may occupy an entire page, listing all the causes of hypoglycemia. But many of those are things that would be self-evident otherwise. You know, you can get hypoglycemia in the terminal stages of liver failure. Well, yes, but by then you have a bilirubin of 35 and you're in coma with flapping tremor. Hypoglycemia isn't the only manifestation. You can get hypoglycemia from big retroperitoneal sarcomas, but by the time they do it, they're huge, enormous tumors. Everybody knows the tumor is there. So the real differential diagnosis of hypoglycemia, as presented on this vignette, really revolves around three things. Is it an insulinoma? Is it reactive hypoglycemia? Or is the patient injecting himself with insulin to gain attention, to avoid commitments or whatever? If a patient has an insulinoma, typically the attacks, the neurological attacks, occur during fasting. It's when the patient skipped breakfast or was late for lunch. Okay, so fasting and the attacks have this temporal relationship. When the problem is reactive hypoglycemia, is the very opposite. It's when the patient eats a big meal that the pancreas overreacts and the patient becomes hypoglycemic. And the individual who injects himself with insulin is typically a person who knows what insulin does. Very often there is a connection with the medical profession. It's a physician or a nurse or a physician's assistant or a medical student, or a relative of a diabetic who has seen the other individual, the relative, inject insulin and sometimes overdo it and end up with hypoglycemia. The minute we read on this vignette that the patient was a second-year medical student, you're already alerted. This is probably going to be self-administration of insulin. But actually there is a proof already here in the vignette, because it turns out that the insulin we make in our own pancreas, either from an insulinoma or from excessive reaction to a big meal, is insulin along which we make also C-peptide. So there would be high levels of both insulin and C-peptide. But the insulin we get in the drugstore doesn't have C-peptide. And so in this particular vignette, we go back. The workup showed that he had high levels of insulin in the blood with low levels of C-peptide. This insulin came from the drugstore. This is injected insulin. And so the next item in the workup of this patient is not the CT of the pancreas. It's actually a referral to a psychiatrist to look into the motivation that led to this action.